All right, I want to begin, as I always begin, by thanking Dave Whelan and the Talbot Spy for creating this partnership with the Talbot County Free Library. It gives me the opportunity to speak with some great writers and poets. My guest today is Dr. Jason Karlawish, who will be speaking about his newest book, The Problem of Alzheimer's: How Science, Culture, and Politics Turned a Rare Disease into a Crisis, and what we can do about it. And I'm going to read this bio because otherwise I'm afraid I'll forget something. Dr. Jason Karlawish is a practicing physician who researches and writes about issues at the intersections of bioethics, aging, and the neurosciences. In addition to The Problem of Alzheimer's, he is the author of a novel, Open Wound: The Tragic Obsession of Dr. William Beaumont, and has written essays for the New York Times, the Washington Post, Forbes, The Hill, and the Philadelphia Inquirer. Dr. Karlawish is listed as an author or co-author on countless academic papers published in the likes of JAMA and the New England Journal of Medicine. He is a professor of medicine, medical ethics and health policy, and neurology at the University of Pennsylvania, and co-director of that revered institution's Penn Memory Center, where he cares for patients. I've just finished reading Dr. Karlawish's book, and I have to tell you, it's so full of remarkable information and great stories that there's absolutely no way we can cover it all in a single interview. So I would strongly encourage you to go to the Talbot County Free Library and check out a copy, go to your neighborhood bookstore and buy one, or go online and get it from Amazon. It's a terrific book. Really well worth the effort. Dr. Karlawish, thank you for being with us. It is an honor to have you with us today. I'd like to begin by asking you how you came to dedicate your life, your career, to such an unrewarding, unglamorous task as caring for us old folks, people who are likely to suffer with Alzheimer's.
But back then, I was a young doctor, and but you're right. Your summary is correct. I chose to go into geriatric medicine, and I would agree it's not glamorous, and yet it made total sense. And it was a convergence of events for me. And in fact, for a while after I finished my residency in internal medicine, I was going to become a critical care physician. So, for example, had I stayed in that, I would have been running an intensive care unit during the pandemic, and ventilating folks and taking care of very sick people from COVID, for example. But that didn't turn out. I actually dropped out of the critical care fellowship, one of probably the only persons to do that for reasons that weren't because I had to or was being kicked out. And the reason why were many. There was a precipitating event, and I recounted in the book. Namely, my grandfather had dementia. We didn't really know what the cause was. We never got clear answers. Certainly that was frustrating, but what precipitated that switch was he fell, broke his hip, and within a few months was dead, despite getting the very best of care at an academic medical center. And I recount that. And that event, together with a series of interests that I had been developing in ethics and in understanding what aging was, said to me, we don't need more doctors in critical care, nothing wrong with that field, but we certainly need more doctors to help figure out how to take care of patients like my grandfather and families like his son and his daughter who struggled over what to do. And so I made the switch, and I never looked back, never regretted it.
I'm going to begin with some of the medical issues that you bring up. What can you tell us about Aricept?
So Aricept, that's the trade name of a drug that is generically known as donepezil. Aricept is one of a class of drugs that are prescribed for the treatment of the symptoms of the disease. And in the book, I have a chapter called Hope in a Pill. And the intention of that chapter was to recount the history of the development of drugs like donepezil. And my goal there was to illustrate how there's really three themes that those drugs reveal. First of all, even at their discovery, and certainly in the years to follow, the field began to realize these really aren't that effective. They do something, and I prescribe them, but let's not pretend they're that effective. And yet that was sort of something we weren't allowed to talk about, And then the question is, well, why is that? And well, I get into the fact that there was a robust business model surrounding those drugs to support a research infrastructure. And I think one has to see both sides there, namely that in a disease at the time, and the drugs were developed in the 90s, for which there were no pharmacologic treatments, finding something that did something was a tremendous incentive to start to do more research to find something better, and also for people to go into the field as physicians. And that's the reality of sort of the business model that underlies medical research as well as medical care in America, and certainly in other developed nations. The second point I bring out was how the in Hope in a Pill was how there was great, it follows from the business model point, there was great support for these pills. You write the script, you get paid for the visit, etc. But at the same time that those pills were being developed and translated into clinical practice, we were also developing very effective methods to help a family better understand what was going on, make a plan of care, and help a patient also better understand what's going on and make a plan of care. In other words, good research of what are called behavioral and social interventions. And yet there was no business model, and still is no business model, to support those interventions. And it sort of shows you how our system is not really set up correctly to take care of patients. And then finally, I point out how those drugs were developed with great desperation to do something. And yet, because the field as physicians and scientists can't admit their emotions, that was never put out there. And I think it's one of the reasons why we sort of spent a bit too much time working on those drugs and supporting them, and not enough time on better therapeutics, as well as supporting the non-pharmacologic therapeutics. So yeah, that was a lot of a fun chapter to write, Hope in a Pill. I enjoyed that one.
You know, talking about pills and the medical treatments for the disease. At one point in your book, you write, a strategy that relies on discovering the cure for Alzheimer's is like planning for retirement by buying lottery tickets. I really like that. Can you tell us what you meant by that?
Yeah, it's a punchy line, but I stick with it. And the reason why I stick with it is, look, I am enthusiastic, and I recount very carefully across the book the progress in science that has occurred to better understand the cascade of events that cause someone to develop disabling cognitive impairments, or in a word, to develop dementia. And I recount the efforts of researchers who discovered ways to visualize the pathologies in a living human, for example. And I recount the scientists who discovered extraordinarily innovative ways to go after those pathologies using immune-based therapies. So progress is occurring. At the same time that that progress is occurring, it's unfolding a very plain fact. And that fact is that this is a complicated disease. It's not like the COVID infection. One virus causes one set of illnesses, and if you could just get rid of that virus, you get rid of the problem, right? With this disease, we see that much like most diseases of aging, there are many different factors at work. And I think most of us get that when we think about cardiovascular disease and cancer, okay? And that's what we're discovering with this disease. There are many different factors at work. And so the point is, we should expect a future where it is a disease you can diagnose early, maybe even before you have dementia. And there will be treatments that will affect the natural history of decline, some effective for some people more than others. But the notion that we're going to drug our way out of this problem the same way that we are vaccinating our way out of COVID is just that. It's a notion. And that's what's leading me to say, it's like planning your retirement, going and buying lottery tickets. I mean, you may win big, but the odds are you're not going to win big, and you put a lot of dollars out there and you're not going to get the return you expected.
Something I didn't know until I read your book, and I have to tell you, this terrified me, was to learn that before patients and their caregivers can qualify for Medicaid that will cover some of the more expensive treatments and care offered that is required for patients with Alzheimer's, before they can qualify for that, they basically have to impoverish themselves. They have to spend out all of their savings, exhaust their funds. And even then, they only qualify, once they qualify, then they're put in a waiting line. And it may take some time before they actually get to the point where they get help from Medicaid. Can you tell us about that?
So I have almost a whole part of the book, part two, the Birth of Alzheimer's, where events pick up in the 1980s when the advocacy group that would come to be known as the Alzheimer's Association is formed by desperate families, the 7 desperate families. And one of the reasons why they were desperate, but not the only, was they couldn't get care. And I recount, for example, the struggles of several women. Many of them were women. One of them, Hilda Pridgian, who essentially had to suddenly take over running a family, making money, bringing in income because her husband Al now was disabled from dementia, and also taking care of him. And she realized pretty quickly that our healthcare system in 1970s, that was the 70s that she took care of Al, was simply not equipped to take care of someone disabled by dementia. And that was one of the motivating reasons why she and other women, many of them were women, got together and formed what would call to be called the Alzheimer's Association. And what they were facing was that, events that go back to the Cold War and the Great Society programs. When Lyndon Johnson signed the Medicare statute into law, I recount how that statute has among its prohibitions of what it does not cover is what was called custodial care, a very disgusting term, I think, thinking that someone's sort of a building and needs a janitor to clean them up. But the point was that Medicare statute was explicitly written to not cover what we would now call long-term care services and supports. Trust me, I like Medicare. We need Medicare, please. But what we didn't include in the statute, and what we've never been successfully able to create, is a similar social insurance program to care for persons living with chronic disabling illnesses. And instead, what we have is a patchwork system that essentially says if you're poor enough, you qualify for Medicaid, and then you have to wait in line because there's a shortage of the resources to Medicaid to provide long-term care services and supports. Otherwise, as Hilda Pridgian recounted when she testified to Congress in the 1990s, people are afraid. I'm afraid. I'm even more afraid of how I would care for someone, let alone afraid of getting this disease. That was the case then. It's still the case now. And I recount in the book how this is a political problem. In other words, it's a failure of our politicians to arrive at a coherent plan about what we're going to do. And I recount how a then congressman, not yet a leader in the House, Tom DeLay, met with a group of activists and essentially behind their back says just that. I don't know how anyone's told me how we're going to pay for this, so I'm not going to cover long-term care social insurance. And we're still living these Cold War fights about the accusations that social insurance like that would be, quote, socialism. And it really just stops the ability to move forward coherently and have a plan.
How about the Affordable Care Act, otherwise known as Obamacare? Does that, I realize that's for younger people, isn't it? But does that have any effect upon the care of patients with Alzheimer's?
Yeah, one of the points I make in the book is, look, we want better drugs, and we will get them. We need a long-term care social insurance program. We might be able to open a conversation about that, especially since COVID has shown how we're all at risk for catastrophic events that can disrupt our lives radically. But there are things we can do now. And one of those things is to further expand the patchwork of what amounts to a social insurance program to provide health care for Americans. And you say, well, no, wait a minute. Obamacare is care for people who are under 65, because over 65, you've got Medicare, right? Well, so what has nothing to do with people with Alzheimer's, because persons living with Alzheimer's disease are typically on average about 77 years of age. But Obamacare has made a big difference for the care of persons with Alzheimer's because Obamacare allows a 43-year-old daughter to get health care and also be able to work as a caregiver. Whereas before Obamacare, most health care was available through your employer, through employer-based insurance programs. And if you're a caregiver, many of them experience what caregiving does to a family, which is you either step away from the workforce or you dial down your participation in the workforce. And prior to Obamacare, that meant you don't have health insurance. And so what Obamacare did unwittingly was provide a safety net of social insurance, of healthcare for that daughter who says, I'm stepping out of the workforce because I got to care for both of my parents. So in that sense, it's really, the Alzheimer's Care Act, not the Affordable Care Act.
I really like the fact that you paid so much attention to caregivers in your book, that they're an important part of the equation with patients with Alzheimer's. And related to that, what can you tell us about adult daycare centers?
I like to call them adult day activity programs. I think that term better describes what they are, and B, kind of pulls away from the pejorative feel of, there's a child daycare center and there's an adult daycare center. But having said that, I actually, in part of the research for the book, went to some of these centers, interviewed the people who run them, learned what they are. And essentially, they're a space that allows a person with disabling cognitive impairments, such as dementia, caused by a disease like Alzheimer's. It's a space for someone with those kind of problems to have a day that's safe, social, and engaged. Um, and so for the person with the disease, it gives them some structure and activity that oftentimes is very difficult for them to get out in the community, particularly when they have moderate to severe stage dementia. Families struggle to organize a day that's safe, social, and engaged, particularly if you're the only one there. I mean, I have caregivers who tell me, I haven't read a book in 5 years. Why? Because my wife is always around me. I can't get enough, I can't get the private quiet time to just sit and read a book. And, actually the caregiver that told me that, I'm like, you really need to get her into an adult day activity program. And I describe what goes on at those programs. And there's a fascinating bit I have about beanbag toss, which the readers can read about if they'd like.
One thing that you talk about that's a real problem with treating Alzheimer's patients is that you have to depend upon the reports of caregivers and the patients themselves on what their daily day is like, how bad they're doing or how well they're doing. They have to recount that for you. And to overcome that problem, there's a doctor out there, I think his name was Dr. K, who's developed a platform of technologies that observe the patient unobtrusively, but as a result that you get a totally objective account of the patient's days and activities. Can you tell us about that?
Yeah, so in this whole we're on the sort of part 3 of the book called Living Well in the House of Alzheimer's. And then the book's a 4-part book. And in part 3, that's where I talk about these things that we can do now. In other words, right now, where we could do these things. And in some places in America, we talked about adult day activity programs. The other thing we can do right now is harness the Internet of Things, the technologies that we have to better detect, monitor, and also intervene to support persons with cognitive impairment. And I made a field trip out to Portland, Oregon, to look at the group set up by a physician named Jeff Kay, a neurologist, who at the Oregon Health Sciences University has this decades-long research project going where he's wired up the houses of people living in various apartments in Portland, your bed to know whether you're on it or not, motion detectors in the hallway to know how often you're up and moving about, your scale in your bathroom, your toilet. In other words, he can basically, your car, your pillbox, he has the ability now to show how your way you live in your world is a way to detect changes in cognition. And he's proven it. He's shown patterns in things like computer use, patterns in medication use that predict incident cognitive impairment. And so what he does is he's upended everything that I was trained to do, which was you got to come to the memory center, you got to bring someone else, they got to tell me what's going on, and then I talk to you. And it's this long sort of, let's reconstruct the last 12 months to figure out what's going on. His work would allow you to essentially download these data and look at the patterns that say this person's developing cognitive problems. How do you know it? Just look at how they're changing in their life. And you know what? Any family member will tell you, yeah, you're right. When I think about what happened with my father, he stopped traveling, the day trips, and he would only go, local. And then his local trips got shorter. And it was only when that's happened that we started to notice that, he's repeating himself. And so you could see all the little signs, pointing towards disabling cognitive impairments unfolding months, years prior. And that's what Jeff Kay's doing. And there's no reason why we can't have that network of Internet of Things part of our healthcare system. We just have to muster the technology and the will to do it. Right now, I saw a patient yesterday at the Memory Center. I sat her daughter down and I interviewed her daughter, and then I sat the patient down and interviewed her, etc. Took about an hour and a half. I'm not saying we shouldn't talk to patients and their family members, but what this would do is it would let me simply look at the private world of that woman who I saw yesterday and look at what she's doing in her own world and conclude from that I'm seeing signs of cognitive impairment. Now, of course, I'm still going to talk to her and her daughter to verify things, but it changes the clinical encounter and makes it much more real world rather than these sort of abstract activities of storytelling that right now are methods to decide that someone has cognitive impairment.
Staying on the subject of technology, you also talk about, and it gave me great confidence. It felt good to find this out, that there are existing technologies, smartphones, banking algorithms to detect fraud, videotaping a message for your future self, robots, all these existing technologies that may help Alzheimer's patients remain independent much longer if we use them properly. Can you tell us about that?
So there's two themes there, and this is in the fourth part of the book, which I call a humanitarian problem. And the reason why I kind of saved those technology bits to the fourth part was I wanted to sort of package together an argument that it's not just about doctors and clinics and hospitals working better. And I lay that all out in part 3. It's not just about the discovery of better drugs. There are things in our daily lives and in other interactions that could allow us to address this problem. And so one of them is the financial services industry. So, as you start to lose your cognition, the things that are most affected earliest are cognitively challenging activities. And certainly one of those is financial management. I mean, the organization and preparation of materials for taxes, investment decisions, bill paying, and the ledgers necessary. Those are all cognitively demanding activities, not very physically demanding, but cognitively demanding. And so as people develop cognitive impairment, oftentimes the earliest signs are mistakes and errors, bad decisions, or being victims of fraud and abuse by other people. Well, the banking and financial services industry, they're basically on the front line to detect those problems. And they know that. And in fact, I've had many conversations and meetings with folks where that's exactly what they tell me. And I coined this idea of what I call wealth care, which I talk about in the book. Readers can learn more about that. It's a clever play on wealth and health, wealth care. You'll see that. So that's that aspect of life. And then the other aspect is to think about how technology could start to begin to become like the way we think of wheelchairs or other motoric devices for people with physical disabilities. We could begin to think about the role of robots to fill in where our minds no longer are working as well as they used to. We could begin to think of robots as helping to do certain tasks, helping us to make decisions, providing us some interaction and engagement. So, in some sense, we could begin to think of robots functioning in the way that humans do, caregivers do. And I push that argument, though, just to also then create some disquiet about that. Because maybe someday with artificial intelligence could design a robot that is all but like a human and you don't know it's not a human. But I think we have to understand that so far only humans seem capable of the amount of moral agency and moral experience that adds up to a human mind. And so I do raise the disquieting point that we're going to miss something if we think we can substitute humans caring for humans with robots caring for humans. Nonetheless, I think robotic technologies offer a lot of possibilities for people to get care and receive care.
At another point in your book, you write, as much as 35% of the lifetime risk of developing dementia is caused by things people can do something about. We all want to know what those things are so we can avoid it. And can you also explain to us why that explains the current decline, the way the rate of Alzheimer's seems to be declining in the world today?
Yeah. So what you're getting at is there's this chapter that opens part 4. And that chapter is called Something Must Be Working. And it begins after the rather sad ending of part 3, where I talk about how the drug trials were either failing or showing very slender results. And yet, part 4, Something Must Be Working, I report how multiple large, well-designed studies have shown over at least the last 4 decades that the risk of developing dementia has been declining. Now, that's a really provocative point. You just told me there aren't any effective treatments to slow the disease. And yet you were telling me that over the last 4 decades, the risk has been declining. So what's going on? Well, the studies answer that question. And that's why, again, I call this a humanitarian problem. because the answer from these studies about the declining risk of dementia are, I think, two words: um, opportunity and access. Namely, what the studies consistently show is that individuals who get through at least about a high school level of education or beyond are less likely than individuals who don't get that much education, less likely to develop dementia. Moreover, the studies show that individuals who have consistent access to good health care, particularly cardiovascular health care, are less likely to develop dementia. And I think the lesson that's behind those studies is things that keep the brain healthy, that keep the neurons healthy, prevent that brain, despite the presence of pathology like from Alzheimer's and other diseases, from developing symptoms as early as they do. And so we're being told already there are things that we can do right now in society that will reduce our risk of the burden of dementia. And as I say, it's about giving people a quality education and all the fruits that follow from an education in terms of opportunity and access. It's called giving people good quality health care for the course of their life. And then when you think about cardiovascular health, it's not just pills, although they're important. It's about a lifestyle that maintains a healthy heart. And we all know what the last 12 months during the pandemic, when we couldn't go to gyms and go to other places, we witnessed, just how important it is to have access to the ability to, go to the Y in Easton and swim, or, use the machines there, et cetera. The value of public health programs to reduce smoking risk. I mean, we could go down the list, but what I'm getting at is these are all things that society can do. They're not things that medicine can do. And that's why we should see this as a humanitarian problem. If listeners want to know more about specific activities they can do to reduce their risk of developing dementia, I would urge them to go to AARP's website for the Global Council on Brain Health. That council has summarized the data around a variety of different activities, what's worth doing, what's not worth doing, et cetera. The Global Council on Brain Health.
What can you tell us? What is cognitive reserve, and how can it protect us from Alzheimer's?
Yeah, well, so cognitive reserve is what we think is created by that lifelong set of habits that create a healthy brain. Once upon a time, we thought we were born with or developed into just as many brain cells as we had, and brain cells didn't grow or otherwise change. That was a strong belief held in the early 20th century. By the end of the 20th century, we realized that brains are a very dynamic organ. They generate new cells, and those cells change their structure and therefore their function. And so this idea of cognitive reserve says there are things you can do that builds a healthier brain. And as I said, the Global Council on Brain Health lays those out.
Another story I really enjoyed in your book was about a psychologist named Lisa Barnes, who, through her research, determined that if she had been born in Boston instead of Chicago, she would be more likely to develop dementia. Can you explain that to us?
Yeah, that again begins this part, the humanitarian problem part. And Lisa Barnes is a very interesting, very thoughtful psychologist who was born and raised in Chicago on the South Side, Hyde Park, went to the lab school. It's an integrated neighborhood of Black, brown, and white Chicagoans. She goes off to, she's smart. She goes off to Wellesley College in Massachusetts to study psychology. And she tells a story that when she's in Wellesley, she and other women of color were set aside, and they were told, when you go to Boston, don't go to certain neighborhoods because you're going to get mistreated. And anyway, she then goes to Boston and she witnesses racism. She experiences racism. She experiences racism and also the sense of otherness, such that she actually takes a semester away to go to a historically Black college down in the Atlanta, Georgia area, and actually would transfer to that school. And later on in her work as a psychologist, she would study the impact of these social and behavioral impacts on brain health, one of which, of course, is structural racism. And I asked her, had you been born and raised in Boston, how do you think you would have turned out compared to being born and raised in the integrated collegial collaborative world of Hyde Park, Chicago. And she said, well, I have to think, if I listened to what my researchers told me, I wouldn't be as healthy as I am. And I thought that was a very moving statement on her part, and really kind of a wake up call about the many different ways our society determines our brain health. No question, amyloid plaques and tau tangles, the two pathologic markers of Alzheimer's, cause a brain to decline. But I think the evidence from her research and others' research is there are a lot of other avenues to make our brains unhealthy. And these are things we can do something about. That's what's amazing. You know, we can change society and make our brains healthier.
You know, reading your book, I found myself thinking that, of course, it's a book about patients with Alzheimer's and their caregivers, but I think it's also a book about doctors and doctoring, the art of medicine, if you will. My dad was a doctor, and I've always been fascinated by your profession. And so I'd like to begin this section of questions about doctoring by asking you why it is, if given how pervasive and devastating an illness Alzheimer's it is, why are so few doctors like you, why have so few doctors joined you in dedicating their lives to caring for people with Alzheimer's?
Yeah, I honestly, I think there are several reasons, but I think one, I think one of them is, um, there's not a good business model to devote your career to the diagnosis and treatment of older adults with disabling cognitive impairments. I remember interviewing a neurology resident who was looking at a fellowship at our memory center, the Penn Memory Center, and she told me how her colleagues, fellow neurology residents, said, "Why would you want to go into that? There's no treatments to prescribe." That, you know, and I've had conversations with very well-meaning medical students who started out wanting to go into my field, but then witnessed the sort of thrills of fields like obstetrics and gynecology and urology and general surgery, and they're like, "Look at all the things you can do." And so I'm going to go into that field. It's also lucrative. Some of those other fields are compared to mine, you know, and I can understand that perspective. I can. Now, actually, though, I disagree. I think there are lots of things you can do. It's just that, you know, if the things that sort of describe cutting edge medicine, namely, you know, pills and tests, we don't have as many. And so I think, you know, for a young person who's scientifically minded, along a biomedical model, I think this kind of practice isn't as attractive, if you will. And you know, I reflect, you know, why is it attractive to me? Well, you know, I'm a writer, and it's a very narrative based field, and so I guess I derive great pleasure out of that aspect. And I will admit, you know, there's certainly medical school seems to be full of young people who want to write books, but I will admit that's not a typical profile of a student. The other, I think, reason is that the brain's a hard organ to study. Up until basically the turn of this century, most brain diseases were very hard to visualize until you died and you were able to do a brain autopsy. And of course, even then, what you're doing is looking at the sort of end stage of whatever the problem was, you know. And I think that slowed the progress of science. And so, you know, it was hard to do research in that space. And then I think finally there are cultural events that are not just in the culture of medicine, but rather in general. I mean, we're talking about a disease which up until 1980 was considered an extreme stage of aging for which there was, quote, nothing you could do about, and more importantly, nothing medicine could do about it. So up until about 1980, medicine just, well, senility is aging. It's not, we just don't deal with that. We don't deal with aging, which isn't true. Talk to a cataract surgeon. But anyway, my point is that I think all those events add up to why there are so few people who would call themselves an Alzheimer's doctor compared to the many people who would call themselves cardiologists or oncologists or even diabetologists.
You know, reading your book and noticing again and again how much time you spend with your patients and the amount of time and thought you give, the reflection you give to your patients and their conditions, I was reminded once again of my father. My dad was known as a great diagnostician, and when other doctors would ask him why he was so good at diagnosing, his response was always the same: because I listen to my patients. You listen to your patients. You spend time with your patients. I have a number of friends. I'm very fortunate to have a number of friends who are physicians, and they all tell me that nowadays they are under intense pressure to spend less time with their patients, to see as many patients in the day as they possibly can. And when I hear that, it frightens me. It frightens me for medicine. Do you think that the field of the profession of medicine is broken?
Well, there's no question that a workup of cognition for a cognitive impairment is time intensive at a minimum, because you need to talk to generally not just one but two people, namely the person who has the cognitive problem, but also someone who knows them well to get a collateral history. And most folks who do the work, cognitive work, will tell you that's their approach. I recount in the book, in at part 3, Living Well in the House of Alzheimer's, the work of a very just brave, um, ambitious, perhaps foolhardy physician named Peggy Knoll, who had a memory center going in the late 20th century, uh, but essentially hit the wall that most centers hit, which is you can't make money on this, and so they were going to shut her down because the healthcare system that ran her center in Asheville, North Carolina, because she was losing money. And she said, I'm not going to do that. And she just stuck to it. And I recount her story. What's interesting about her story and how she succeeded was how rare she is. And what it's getting at is there just isn't a business model to support a memory center. Our memory center at Penn exists because of cross subsidization and of projects, et cetera, from research, as well as, frankly, generous philanthropy. Our social services and supports are made possible by a very large gift from a gentleman named Eli Kaplan. So right now in America, it's hard to find a memory center unless it's a research operation, and some of them are clinical trial shops, for example. And the reason is because, a disease doesn't fully exist in America until it has a business model, meaning it's worth the doctor's time to spend time on this disease. And that's not been the case with the workups for and care for persons living with dementia and their families. In the Netherlands, a primary care doctor for a workup of a cognitive complaint is allowed 3 20-minute sessions spread out over the course of a couple visits, which would add up to the kind of time you need to do that. And that's paid for in a way that doesn't have them, quote, lose money, but rather deliver care and be supported to do it. So you can do this. You just have to muster the political and financial will.
Talking about the medical system as it exists today, not as we would have it be, can you tell us a little bit about the story of Alzheimer's patient Darren Johnson and how the current model of care, followed by most doctors, failed him?
Yeah, so the story of Mr. Johnson, it opens part 3, Living Well in the House of Alzheimer's, he and his wife Beverly. And essentially, they are a very typical new patient visit at the memory center. Namely, they spent years trying to get an answer about what's going on. And finally, when they show up at the memory center, they've gotten all these mixed messages and pills without an answer. And, there's this sort of sigh of relief when we sit them down, figure out what's going on, disclose the diagnosis, make sure it's understood. And then probably just more importantly, now that there's a diagnosis, is not to say goodbye, but rather to say, okay, let's now meet with our social work team to put together a day that's safe, social, and engaged, and then get access to the services that are needed to do that. And that's what we offer at the Memory Center, a separate visit with our social services team to help put together a care plan. And I recount how that worked for them for a while, and then I recount, of course, how as he got ill and entered the medical system because of a hip fracture and other events, much like what happened to my grandfather, things went awry, if you will. And I use that case that opens part 3 of the book as a springboard for, again, the things that we can do now to improve care for persons living with dementia and their family members. Cautiously optimistic, though, that America awareness has been raised. I think that one event among several events that give me hope are over the last 25 years, awareness has been raised about Alzheimer's disease. I think the next step now is to implement education within the healthcare system for how to diagnose and care for patients. And, as awful as COVID was, and as much as I wish it never happened, There's some copper linings from it, if you will. One of them is we discovered we can do telemedicine. We went from not doing it to doing it, and that holds enormous promise to get people access to diagnostic services, as well as for training. The last 12 months have been just a crash course in that. And so I'm cautiously optimistic going forward that we might be able to better organize the delivery of care and education to the healthcare system.
Reading your book, I was struck again and again by the amount of time, effort, thought, reflection you put into caring for your patients, not just their physical care, but also the moral and ethical issues involved in caring for them and helping the caregivers. It's very complex, and I would have thought would be difficult on you personally. How do you take care of yourself? How do you keep your spirits up? How do you keep going? Your patients need you. I trust you have a method for that.
Oh, one point about the time I spend, I do spend time, I will say, but I would argue it's time, dare I say, well spent. When oftentimes residents, medical students will tell me, I spent a lot of time with that family. And my answer generally is, I really don't care how much chronologic time you spent. What was the quality of that time? And oftentimes I find that the time that they spend is the time that they spend talking and not much listening. I know that sounds a little grumpy and old Dr. Karlawish, but the mere passage of 60 minutes with a patient doesn't make the encounter any good. But if you do it right, at least a new patient visit does take about 60 minutes. Anyway, if it's time, though, well spent, it's rewarding. True, it's exhausting, I would agree. And at the end of a clinic day, I see patients once a week. It's exhausting. It's not exhausting because it's been physically busy, standing up doing a 9-hour surgery, but it's exhausting because it's a very cognitively intense activity. So what do I mean by that? The conversations I have with patients and families, I think if you heard one, you'd say it's pretty uninteresting content and it seems like just a chat, but it's not. It's actually incredibly guided on my part and very organized. It's like a well done script, I would say, and that is cognitively intense. It's also, though, very rewarding. The topics seem ordinary, but behind them are extremely morally and ethically challenging issues, very personal issues. Now, and so apropos, I suppose the fact that I see patients one day a week roughly is probably why, I do it. Maybe if I saw them more frequently, I have colleagues who do, they're content to it. But, what else do I do? I'm a writer and I'm a researcher, and certainly that gives me other kinds of occupation and activity that I find rewarding. I frankly also, to maintain my health, I listen to what the data I told you earlier, which is, I focus on my heart health with exercise, diet, and I'm a big proponent of the red wine hypothesis to reduce the risk of dementia.
I'm awfully glad to hear that. There's nothing like a good Pinot Noir to keep your heart healthy. Well, as you said, a good book is not just the reading of it, it's that after the reading, a good book has changed us. And I want you to know that your book, The Problem of Alzheimer's, which I highly recommend everybody go out and buy or check out of the library, changed me. It gave me an entirely different perspective on the treatment of patients with Alzheimer's and the way our world responds to them. Thank you so much for Dr. Karlawish for all you're doing for these people. You are, in my humble opinion, a great humanitarian. And I think everyone who reads your book will agree with me about that. Please take care of yourself, sir. We want you around for a long, long time.
That's very gracious of you. If folks